Maybe one question which constantly comes from clients, it's about the sequencing. I know there was a discussion also during EHA. Yeah, what about, do you start with CAR-Ts and then bispecifics come after? So especially sequencing bispecifics and CAR-T. What is your opinion on this? Where do you think this goes?
So of course, this is a good question. If we compare the response rates and the median PFS between CAR-T cells and bispecifics, because probably for us as prescribers, as physicians, we will be tempted to use the most efficient agent first, and the agent associated with the longest median PFS first, even if the CAR-T cells may be a bit more toxic. If we take a look at the CARTITUDE-1 clinical trial, the median PFS is 31 months. It had been updated in the last ASCO. If you compare it to the median PFS with bispecifics, whatever it is, it can be teclistamab, elranatamab, paverutamab, is approximately 12 months in the same subset of patients. So we can consider that probably talking specifically about about cilta-cel, Carvykti, probably Carvykti is more efficient than any other anti-BCMA bispecifics. So in young and fit patients, specific patients with high-risk characteristics, we will probably be tempted to use cilta-cel first, and then we will be able to use bispecifics after. We tend to have some evidence to support the remain efficacy of bispecifics, even targeting BCMA after anti-BCMA CAR-T cells, even if it could be also logical to use GPRC5D bispecifics after anti-BCMA CAR-T cells. Regarding Abecma, clearly the difference is much less significant as compared to bispecifics, because the median PFS in the KarMMa-2 clinical trial is approximately 12 months, which is approximately similar to the one of bispecifics anti-BCMA. So here I think the discussion is more open. We have some advantages of CAR-T cells over bispecifics and vice versa. For us as prescribers, clearly the turnaround time and the median delay between apheresis and reinfusions is a crucial point. Currently in France, the turnaround time with Abecma is approximately 3.5 months, which is very, very important, as compared to 40 days in anti-CD19 CAR-T cells for the treatment of diffuse large B-cell lymphoma, for example. However, we just received a good news from Celgene BMS very recently, 2 days ago, after the result of the KarMMa-3 clinical trial, which was the phase 3, comparing Abecma to standard of care, and they are going to increase approximately by 3-fold the number of available slots for Abecma in the next 2 months for France. So probably the obtention of phase 3 data will permit us to obtain more frequent slots to propose to our patients. So we will probably have a wider and easier accessibility to Abecma in the short term, and maybe the same for Carvykti in the short term as well. However, the availability and accessibility will probably always be less important with CAR-T cells. Currently in France, we only have 8 centers with access to anti-BCMA CAR-T cells in multiple myeloma, versus more than 30 having access to anti-CD19 CAR-T cells for treatment of lymphoma. And clearly, bispecifics can be given by any hematology centers, including community hospitals and private clinics, which will never be the case for CAR-T cells. So this wide availability, the better safety also with bispecifics. The CRS rate overall can be up to 60% with the bispecifics, but the majority are grade 1-2. We virtually never have any grade 3-4 adverse events with bispecifics, so it can be easy to use in much more elderly patients, in patients with some comorbidities. And there is also a potentiality to develop those bispecifics in first line, as mentioned before, in combination with daratumumab, PIs, and IMiDs, which will probably never be the case with CAR-T cells, maybe, except in some selected patients with high-risk characteristics. I think you might be aware of the CARTITUDE-5 clinical trial. dedicated to the treatment of patients who are not eligible for stem cell transplantation with high-risk characteristics, with an induction with VRD, followed by CAR T cells. So there is a randomization between CAR T, cilta-cel basically, versus VRD based on the SWOG clinical trial design. So that we might have access one day to CAR T cells in first-line setting in patients who are not stem cell transplant eligible. But we will, of course, need to have results of this CARTITUDE-5 clinical trial, which is underway, hence which has just studied the first inclusions.